Good morning, good evening, good afternoon. I'm Johnny Mahlangu from Charlotte Maxeke Johannesburg Academic Hospital. As you know, the WFH guideline for management of hemophilia is a high quality, expert and evidence informed guideline that is going to be used by both the healthcare providers as well as the patients. The guideline is available at the WFH website free of charge, and this is the picture of the actual guideline. I'm going to talk to you about the chapter 7 of the WFH guideline, which deals with the treatment of specific hemorrhages. These are my disclosures. They reflect my clinical trial activities with a large number of role players in this field. Just to remind you that the putting together of chapter 7 of the WFH guideline was a team effort. The team comprised of a number of individuals. These individuals included the healthcare providers, the people with hemophilia, under the guidance of the content leads. And thank you again to the WFH staff who are supporting these guidelines throughout, as well as the external individuals who were brought in to provide the expertise. The guideline is a group effort, as you would imagine, comprising of a number of individuals. The healthcare providers in the guideline included, in addition to myself, Gerald Dolan, Alison Dougal, Nicholas Goddard, Margaret Rugby, Jesse Windiker. The people with hemophilia who were participants in the group were Enrique Hernandez, Bradley Rayner, and the content leads were Glenn Pierce, who's the WFH Vice President Medical, and Alok Srivastava, who was the lead author of the guidelines. And as I said earlier on, the WFH staff and external consultants were critical in supporting the guideline. Just to remind you that the hemophilia is, the bleeding phenotype is fairly diverse. The patients may present with bleeding into the skin. They may present with bleeding into mucous membrane. Bleeding may occur into muscles, which is not that common. They may present with organ-threatening bleeds, such as in this patient who was bleeding into both eyes following trauma. The bleeding that usually worry most of us is life-threatening bleeds, such as bleeds into the intracranial space. But the most common site of bleeding for these patients is bleeding into the joints, as shown by the right knee bleed in this patient. Different bleeds will require specific management. And in chapter 7, we dealt with specific management through a number of sites. These sites include hemarthrosis, in other words, bleeding into the joint, central nervous system bleeds, neck and throat bleeds, gastrointestinal bleeds, bleeding into the eye and the kidney, mucous membrane-based bleeding into the oral cavity, nosebleeds, lacerations, as well as soft tissue bleedings. It is in this context that the expertise came out with 37 consensus recommendations relating to the bleeds at these specific sites. You will agree with me that if I were to describe each one of those in details and go through the recommendations, it will need a lot more time than we have in this presentation. It is therefore important for me to focus this presentation on specific bleeds, and we are going to focus on the most common site of bleeding in hemophilia, which is hemarthrosis, as well as the bleeding that is life-threatening, and to highlight the importance of early intervention to limit the extent of bleeding and to reduce the bleeding complications. Just to remind you the importance of early intervention, the short-term benefits are many. They include fast relief of pain, early mobility if the bleed involved the musculoskeletal system, the reduction in hospitalization, the lower rates of rebleeds, and of course the reduction in the cost of hospitalization and the drugs associated with management of these patients. And the longer term benefits of early interventions include the reduction in arthropathy, less disability, putting orthopedic surgery out of business, and of course the improvement in the quality of life of these patients. So there's no doubt in my mind that early intervention is important. And of course, the most important question that one always asks is, how do we intervene early? And let's use hemarthrosis as an example of the early intervention. And that's what I want to focus on. As you know, the clinical hallmark of hemophilia is bleeding into the joint. As you can see in this picture, the right knee has a hemarthrosis. In a subset of patients, this hemarthrosis may develop into chronic synovitis. Chronic synovitis may lead into end-stage arthropathy, as you can see in this picture. Of course, the associated musculoskeletal dysfunction, and radiologically is shown as destruction of the joint. The good news is that this process can be prevented, and in some instances, in fact, be slowed down through replacement therapy. So replacement therapy globally is now the accepted standard of care for patients with hemophilia. In the management of hemarthrosis, there are a number of steps that are important for successful management of hemarthrosis. These steps start with making the early diagnosis, early treatment, the use of adjunctive therapies, and of course, the rehabilitation of patients who have had musculoskeletal bleeds. And I would like to take you through each one of these management stages of a hemarthrosis. Let's start off with early diagnosis. Of course, one needs to recognize the hemarthrosis, which is an intra-articular bleed as such, as distinct from arthropathy. It is in that context that a number of features have been well characterized and defined to be able to make that call as to whether one is dealing with a bleed or an arthropathy. And these features include increasing swelling or warmth of the skin over the joint, if it is a joint bleed, increasing pain, and progressive loss of range of movement or difficulty in using the limb. Any one or more of these would then give one the assurance that you are dealing with a bleed as opposed to arthropathy or any other discomfort that might be experienced by the patient. If one then has identified a bleed as such, the next logical thing to do is to intervene. Early treatment using replacement therapy and of course pain management are important. Early treatment, the goal of early treatment is to stop the bleeding as soon as possible. And the reason for that is that the longer one waits, the more likely that the amount of blood that is in the joint is large and which will take longer to resolve. And we use clotting factor concentrate, which is then administered immediately. And it has to be administered at a sufficient dose to be able to arrest the bleeding. In some instances, and very rare instances where there might be confusion about whether one is dealing with a bleed or not, the use of additional modalities such as ultrasound may be useful in making that assessment as to whether one is dealing with, for example, an arthropathy as opposed to a bleed. And of course, any intervention needs to be followed by the monitoring the response to treatment, and I'll talk to the response to treatment later. Our recommendation in chapter 7 is that if one is dealing with a patient with severe hemophilia presenting with a hemarthrosis, they should be treated immediately with an intravenous clotting factor concentrate until the bleed is resolved. We normally do not stop unless of course, there is a reason to believe that the bleed has already resolved. This recommendation is distinct from that recommendation we have made for patients with mild and moderate hemophilia, in which it is possible to be able to treat the bleed with just one dose of intravenous infusion of clotting factor concentrate. And the reason for that is that these patients already have a certain level of clotting factor, and the additional clotting factor is meant to top up what they already have, and therefore there's often no need for them to have multiple infusions until there is resolution of the bleed. Of course, the treatment of the bleed needs to be monitored. And how do you know that the patient has responded? We use the standard 4-point response grading system comprising of excellent, good, moderate, and no response. A patient is thought to have an excellent response if there is complete pain relief, as well as and/or complete resolution of signs of the bleed in the first 8 hours after the treatment has been started. The patient is thought to have a good response if there is significant pain relief and/or improvement of the signs of bleeding in approximately 8 hours after the initial infusion of the clotting factor concentrate. And they are thought to have a moderate response to treatment if there is modest pain relief and/or improvement of signs within 8 hours after the initial infusion. And finally, they are thought to have no response if there is no or minimal improvement or condition worsens despite having received replacement therapy in the first 8 hours after the initiation of the treatment of the bleed. Very, very useful approach to management of response to treatment. And of course, almost every bleed is associated with pain. The pain management is a very important component of management of hemarthrosis. And in this regard, we've got a number of recommendations. The first one is that all pain should ideally be graded using a grading system, and the WFH guideline recommend the WHO pain scale for grading the pain. Once the pain has been graded, logically an appropriate analgesic agent will be used. For mild and moderate pain, agents such as paracetamol may well suffice. For severe pain not associated with inflammation, one may want to use opioids or tramadol. And of course, we encourage the use of COX-2 inhibitors for those patients with chronic pain associated with bleed, so that there is avoidance of the use of other non-steroidal anti-inflammatories, which are known to exacerbate the bleeding environment. If one looks at the use of opioid for the first time in this guideline, the WFH guideline would recommend the use of opioids in patients with severe pain. And of course, the second recommendation here is that one needs to limit the duration of the use of opioids, of course, for the fear of addiction and or reluctance of the patients to come off the opioids if they've been on it for a long time. This is a different recommendation from the previous guideline, where the use of opioids in fact was discouraged and not recommended. There was sufficient evidence that we could come out with to be able to recommend that the use of opioids is actually appropriate for patients with hemophilia. If one moves on to the adjunctive therapy, the RICE and the aspiration of the joints, there are a number of acronyms that summarize the non-replacement therapies that we use in patients with hemophilia. They include RICE, which stands for rest, ice, compression, and elevation. They include PRICE, in which there is addition of protection in addition to rest, ice, compression, and elevation. And they include POLICE, in which the rest is replaced by optimal loading. It suffices to say, of course, that the use of simple ice has been shown to reduce pain associated with acute hemothrosis. And that has been used for a long time by many around the world. So the recommendation with regard to adjunctive therapies is that we would recommend the use of adjunctive therapies, whether it is in the context of RICE or PRICE or police. It is noteworthy, of course, that in many parts of the world, there will be instances where patients do not have access to replacement therapy, in which then the adjunctive therapies then become the primary modality of management of hemothrosis. And in fact, it is important that everyone becomes familiar with the adjunctive therapies. The one area that was and has been controversial for some time is whether hemothrosis should be aspirated or not. In the current guideline, there is firm recommendation that in patients with hemophilia without inhibitors who are on factor replacement therapies who present with a hemothrosis and pain, that the pain may well relate to the tense blood in the joint, and that in fact the arthrocentesis in that setting may well be recommended. It is also a further recommendation that arthrocentesis routinely done on every patient with hemothrosis is not recommended. It is obviously noteworthy that this guideline is meant for people around the world, and in many health settings, arthrocentesis is not commonly practiced because of fear of introducing intra-articular infections. Once one has managed the hemothrosis, if the bleed was in a musculoskeletal environment, one would like to go into rehabilitation. And the rehabilitation, in fact, is important, that there are certain aspects of rehabilitation that are not overlooked. The most important one is that if the bleed happened in an environment such as the hip, the knee, the ankle, one should restrict the weight bearing until the bleed has resolved to an extent where there is a pre-bleed joint range of movement being attained. That requires continuous assessment by both the healthcare providers and the physiotherapist, and tailor that to the individual's clinical needs. The recommendation, of course, is that one needs to hold back on using the joint if one is to get successful rehabilitation. The additional recommendations relating to rehabilitation is that it is important that the individuals who are undergoing rehabilitation do so under factor cover. By factor cover, it means that they receive a clotting factor prophylactically prior to undergoing the rehabilitation program. And the aim or the goal of rehabilitation should always be that the target should be a pre-bleed joint range of movement and function that the patient had prior to getting a bleed. I want to move on now to the life-threatening bleeds, and the most important one is the bleed into the central nervous system. In this regard, I want to give you a small example of one of our patients who was seen in a secondary hospital complaining of a persistent headache that was not responsive to analgesia. The secondary hospital decided to do a CT scan. As you can see, the CT scan showed an intracerebral bleed, and it so happens at that stage that this individual did not receive clotting factor and was transferred to us, a journey which took 3 hours. When the patient arrived in our center, in fact, they complained that the headache had gone worse. We repeated the CT scan, and the CT scan, in fact, was consistent with an enlargement of a previously small bleed that had gone much bigger. And the biggest lesson, I think, out of this anecdote is that early replacement therapy should precede any diagnostic or any other procedures that are planned on the patient. Of course, our patient did not need any procedure. They just needed to be transferred to us. And there was a delay in the patient getting the replacement therapy. And the recommendation from the current version of the WFH guideline is that in hemophilia patients presenting with suspected central nervous system bleeds, clotting factor concentrate should be administered immediately prior to any other procedures being performed. And that is the lesson that, of course, we've learned from this patient. And the second recommendation is that it's not sufficient to just give a single dose. In the setting of patients, it may well be necessary to maintain that prophylaxis so that the patients do not get a rebleed. So secondary prophylaxis is recommended to prevent the recurrence of the bleeds in those patients. If I move to a second life-threatening scenario, and that is the bleeding to the throat and the neck, give you an example of one of our patients who had flu-like symptoms, and he noticed that, in fact, inside his mouth, there was a clot sitting in his uvula, and he had the common sense to take a picture of himself, at which point he consulted us. I just noticed that he was having a slurred speech, and I decided to look under his tongue, and in fact, he was having a hematoma under his tongue. And to cut the long story short, within a couple of hours, this patient needed to be admitted to an ICU with an extensive throat bleeds. He needed a tracheostomy. And I won't show you the picture of the tracheostomy, but I'll show you the picture after this patient has been healed from a massive throat and neck bleed that he experienced. And of course, we saved his life. And the bottom line is when patients do experience throat or neck hemorrhage, these become medical emergencies. And in this regard, there are a number of recommendations from Chapter 7. The first one is that these patients need immediate clotting factor replacement, and they also need critical evaluation by appropriate healthcare providers. And the reason for that is that these patients are likely to deteriorate if they just get a clotting factor and be left alone. And perhaps more importantly is the second recommendation with regard to the throat and the neck hemorrhage is that one should not give a single dose and stop. One needs to continue until the bleeding is resolving or has resolved. What is very useful is captured in the third recommendation, and that is if this bleeding is relating to mucous membranes, the use of antifibrinolytics is very, very important. As you know, antifibrinolytics have got a high efficacy of stopping the bleeds associated with mucous membranes. And of course, some of these bleeds are initiated by infection, like in our patient. So the use of antibiotics may well be of value. And these are part of the recommendations that we put together in Chapter 7 with regard to managing throat and neck hemorrhage. The most important table in this chapter is the table that I am showing now, and I apologize, this table looks very complex and much more simpler than it looks. And I'll take you through aspects of the table. You recall that in the previous version of the guideline, we had recommendations for low resource and high resource environment, a dichotomous scenario which we tried to move away from, but we did recognize, of course, that around the world there are practice patterns that are quite prevalent in low resource environments and those that are prevalent in high resource environments. And that is what this table was put together to do. The practice patterns talk to the various sites of bleeding, and it is noteworthy that in some instances, the initial treatment is not sufficient. One will need to give maintenance treatment, as is the case, for example, with the iliopsoas, deep muscle bleeds, intracranial bleeds, gastrointestinal bleeds, etc., etc. The second component of this, we did recognize, of course, that one is dealing with two different phenotypes, hemophilia A and B, and that the approaches in terms of clotting factor replacement may well be different. We recognize, of course, that in some instances, people may choose a practice pattern in which the lower doses of clotting factor are used, and in some other instances, higher doses of clotting factor are used. And this table gives guidance as to what should be the peak factor level in the setting of low dose practice pattern and the high dose practice pattern, as well as the duration of the treatment that one could expect to treat the patients. As an example, if one takes a joint bleed, which is much simpler, you can see here that in a low dose practice pattern environment, one would aim to have a peak factor level of 10 to 20 units per deciliter for 1 to 2 days duration of treatment. In a high dose environment, one might increase that to 40 to 60 units per deciliter for the same duration of treatment. And it so happened for the management of the joint that the practice patterns for hemophilia A for the joint bleed is exactly the same as the practice pattern for the joint bleeds for hemophilia B. And of course, there are differences between the two hemophilia phenotypes. And then finally, just to summarize, I hope that I have communicated to you that early diagnosis is crucial to successful management of specific hemorrhages in patients with hemophilia. And I've also hoped that early treatment with clotting factor concentrate is the standard of care that is now accepted around the world. We do recognize, of course, the importance of adjunctive therapy, but that is not the standard of care. Replacement therapy is the standard of care. And that, by and large, treatment should be given in sufficient quantities and duration, as reflected in the previous table, to be able to achieve hemostasis, and that the treatment of specific hemorrhages should ideally be individualized and targeted with outcomes that are well defined per site of bleeding of the patients. And finally, that both the low dose and the high dose practice patterns are acceptable in the management of specific bleeds in hemophilia. That is all I wanted to share with you. Thank you very much for your attention. I would like to thank the Hemophilia Alliance and the supporting role of the WFH staff in putting this presentation together.